Okay guys, in this video we will be studying GIT Pharma and the learning objectives will be peptic ulcers, GERD, anti-emesis, diarrhea, constipation, IBS and IBD, which are irritating bowel syndrome and inflammatory bowel disease, right? So basically why these conditions happen, because basically we have these two factors. First one is referred to as the aggressive factor, right? And the other ones are defensive factors. So there is you can say a balance between these two factors, and when these factors they are unbalanced, then this results in the peptic ulcer or GERD, right? The factors which are aggressive, they are acid, pepsin, bile, right? So these are referred to as aggressive factors. When they are increased, so what happens? They lead to peptic ulcer or GERD. But in defensive factors, these are the defensive factors which are mucus, bicarbonates, prostaglandins, blood flow, if the blood flow is decreased, and restitution and regeneration, right? So if the defensive factors are decreased, then this would also lead to the peptic ulcer and GERD. So our first condition is peptic ulcer and GERD. So basically it has two main causes. The two main causes are Helicobacter pylori, and it can also be caused by the NSAID use. And the other factors which are leading to the peptic ulcer and GERD, they are increased HCl and decreased mucus. Okay, now we are going to discuss the treatment approach of the peptic ulcer. Now the treatment approach would include these 6 medications. So the first is the antimicrobial agent, right? The second class is H2 receptor antagonist. Okay, we will give the antimicrobial agents. These are basically, the antibiotics. So we would give this class of medication if the person would get the peptic ulcer or the GERD because of the Helicobacter pylori. So this would help to eradicate the H. pylori infection. Right, the second class is the H2 receptor antagonists and the PPIs. So basically their function is to decrease the acid secretion. Right, then we would have the mucosal protective agents, prostaglandins, antacids, right? Antacids would help to neutralize the acid if it is already synthesized, if it is already secreted into the stomach, right? And these mucosal protective agents would help to protect the mucosa, right, from the damage, and the prostaglandins would help too in this condition, as well as the prostaglandins also helps in decreasing this HCl secretion. Now I have this figure. So basically it is a summary of all of these drugs and their mechanism of action, so you may get a help from that in order to memorize all these drugs. So basically the HCl secretion occurs in this parietal cell, and how this happens, basically the parietal cell has these 4 receptors on its surface. So the first receptor you can see here is the M3 receptor, which is for the acetylcholine. The second receptor is the H2 receptor, which is for the histamine. The third is the E2 receptor, which is for the prostaglandin, and the fourth is the CCKB, which is for the gastrin, right? So these all 4 receptors, they are basically controlling the actions, they are controlling the mechanism which finally leads to the secretion of HCl, right? Now how they are leading to the secretion of the HCl. So when the ACH, which is the acetylcholine, it binds to the M3 receptor, it increases the calcium levels in the parietal cell. And similarly the gastrin, when it binds to the CCKB receptor, it also increases the calcium level inside the parietal cell. So and yes, we have the histamine. When it binds to the H2 receptor, it is a G stimulating receptor, right? So it would stimulate the acetyl adenylate cyclase, right? And this would increase the cyclic AMP levels. So these increase in the calcium level and the cyclic AMP, this would stimulate the ATPase, which is a hydrogen potassium pump, right? And this would cause the influx of the potassium and the efflux of the hydrogen into the lumen of the stomach, right? And the chloride is also excreted by this parietal cell into the lumen, and it is basically by the passive diffusion, right? So this H hydrogen ions and the chloride ions, they would join together and would form the HCl, right? So there is a HCl secretion. Now you can see in the stomach. Okay, now while on the other hand you can see the prostaglandin, when this prostaglandin binds to the E2 receptor, it has an opposite role, right? So this pathway is basically G inhibitory. It means that if the prostaglandin would bind to the receptor, this would you can say inhibit the adenylate cyclase, right? And this would lead to the decrease in cyclic AMP levels, and there would be no HCl secretion when the prostaglandin is binding to the receptor, right? Now we have some drugs, so we can see the mechanisms as well. Okay, so for inhibiting, as you know that the HCl secretion is basically a main thing, right, which is which is leading to the peptic ulcer. So if we would basically inhibit these receptors, the HCl, the receptors which is binding the ACH, which is binding the histamine, which is binding the gastrin, so these all receptors can lead to decrease HCl secretion, right? But if we would stimulate this receptor, right, the prostaglandin, where the prostaglandin binds, so this can inhibit the HCl secretion. So now you know that so this would make it easier for you to remember all the drugs. So for blocking the histamine, you have these drugs: cimetidine, famotidine, nizatidine, and the ranitidine, right? And for blocking this so for blocking the CCKB, you have different drugs, and I have mentioned it later on. Okay, for inhibiting the ACH receptors, we have dicyclomine, telanzapine, pyrazapine, but they are not commonly used, right? And for stimulating this prostaglandin, so we have a misoprostol, right? Then and yes, the mechanism of action of the misoprostol is that it increases the blood flow, right, of the lumen of the stomach, right? And in this way, it increases the healing process. And what you can do also is that you can directly inhibit this proton pump. So for inhibiting this, you have the drugs which are named as basically put into the main category, which are named as a PPIs, the proton pump inhibitors, right? And this category includes the 6 drugs, which are lansoprazole, deslansoprazole, esomeprazole, omeprazole, pantoprazole, and the rabeprazole. So these are all the drugs that can basically block this pump, and in this way this would inhibit the HCl secretion, right? And then you can also use some mucosal protective agents, which include the sucralfate and bismuth subsalicylate. I will tell you the mechanism of action of these, okay, later on. And then we have antimicrobial agents if the H. pylori is responsible for the infection and the inflammation inside the lumen of the stomach, so you can give the triple therapy and the quadruple therapy for that. And you can, but if the acid is already synthesized, right, if it is already secreted into the stomach, then you can give the antacids to neutralize that acid, right? And the neutralizers would include these 3 agents. We have the aluminium hydroxide, we have magnesium hydroxide, and the calcium carbonate, right? And this would basically react with the HCl and would form the salt plus water, and in this way it would increase the pH of the stomach, hence neutralizing the acid. Okay, and once again here you can see the receptors which are found in the different cells which are in the stomach. So in the stomach, you know that we have a different kind of cells. We have the G cells, we have E cells, we have the parietal cells, right? So here are the receptors which are found on these cells. So the G cell has M3 receptors, only M3 receptors, right? The ECL has, which is the enterochromaffin like cells, right? So these cells, they have these 2 receptors, the CCKB receptors for the gastrin and the M1 receptor for the acetylcholine, right? G cell was also having the M3 receptors, which is for the acetylcholine, and the parietal cell has 3 receptors, right? One for the ACH, which is the M3 receptor. It also has the H2 receptors and the CCKB, right? So first of all, what happens is that when the brain, it gives a message, so it releases the ACH, right? And this ACH would stimulate all of the cells, right? Because all of the cells has a receptor. They have receptors for the ACH, right? Parietal cells has MCH, right? And the ACH would bind to the M1 receptor on the ECL, and it would bind to the M3 on the G cells, right? So in this way, when the ACH would stimulate this G cell, it would release the gastrin that would bind to the CCKB, right? So the 2 of the receptors are occupied here in the ECL. One receptor was occupied, okay, in the G cell. And now when these 2 cells, they would release their product, the ECL would release histamine that would bind to the parietal cells receptor, right, the H2 receptor, And this G cell would release the gastrin that would bind to the ECL as well as the parietal cells. So all of the three, when all of the three receptors are occupied on the parietal cell, it would lead to what? The secretion of HCl, right? So in this way, this secretion happens. So now let us discuss the antimicrobial agents first. So basically their mode of action is that they basically eradicate the H. pylori infection, right? The H. pylori agents, which are the gram-negative bacteria, and the diagnosis is by the endoscopic biopsy, and you can also use the non-invasive methods that would include the serology and the fecal antigen test, the urea breath test, right? The treatment includes the quadruple therapy and the triple therapy. In the quadruple therapy, we give four drugs, which are the PPIs, tetracycline, and metronidazole, bismuth subsalicylate, right? In the triple therapy, what we give? The 3 drugs, right? And this includes the clarithromycin, amoxicillin, and the PPIs. Now we have a second class of the drugs, which are H2 receptor antagonists. These H2 receptor antagonists basically causes the decreased HCl secretion both in the basal and the mid stimulated, right? In 70% of the cases. Then the mechanism of action of these drugs is basically these are reversible competitive antagonists of the histamine. It means that it would competitively inhibit the H2 receptors, right? Now these drugs include the 4 drugs. We have the cimetidine, famotidine, ranitidine, and the nizatidine. So the cimetidine is basically the first antagonist, and the adverse effects and the drug interactions are much greater. That's why the PPIs are more preferred, right? And the ranitidine has 50% of the bioavailability. Nizatidine has basically the less first pass effect as compared to the other 3. Then we have the therapeutic uses of these drugs. So first of all, we can use them in the peptic ulcers. So the H2 receptor antagonist can be used for the nocturnal acid suppression. But if the peptic ulcers are caused by the H. pylori, then we can use the PPIs and the antimicrobial agents. These are more preferred as compared to the H2 receptor antagonist. But also, if the peptic ulcers are caused by the NSAIDs, if these are NSAID-induced ulcers, then again the PPIs are more preferred. The second condition which can be treated by these drugs, the condition is acute stress ulcers, or you can say the stress-related gastritis, and this would lead to the bleeding, right? So you can control it by the IV infusion given, which is for the H2 receptor antagonist, but you know that they have the more tolerance. That's why the PPIs are more preferred, right? And for controlling the bleeding incidence, what you can give is the PPIs, and concomitantly you can also give the H2 receptor antagonist. And basically the combination of these two would increase the pH of the stomach, right? And this would decrease the bleeding incidence. Then you can also give these agents for the GERD, and they are effective for the H2 receptor antagonists. They are effective for the heartburn and the GERD, and you can also give them prophylactically before meal, and so basically they would have the effect after 45 minutes in the heartburn, right? The antacids, they are quick but short acting, right? For the severe and the frequent heartburn, you can give the PPIs. So the PPIs are more preferred if the person would have the severe and frequent heartburns. Then we have the non-ulcer dyspepsia, and the non-ulcer dyspepsia, if it is not caused by the peptic ulcers, then you can give the H2 receptor antagonist. Now discussing the pharmacokinetics of the H2 receptor antagonist. So H2 receptor antagonist basically decreases all of these. It decreases the acid production, it decreases the gastrin release, it also decreases the pepsin release, right? It is orally well absorbed, and the volume of distribution is very high. So but it also is excreted in the milk, so it is contraindicated here, right? And the H2 receptor antagonists, they can also cross the blood-brain barrier, they can also cross the placenta, hence this is very much important, so you should remember this, right? And it is also excreted in the urine, right? Okay, then now if there is a renal dysfunction, So the kidney problems, they can greatly increase the half-life of the drugs, so the drugs would stay longer in the body. Hence the dose reduction is required if there is a kidney problems, right? Now the adverse effects. So estrogen receptor antagonists, they are generally well tolerated, but the simridine has very important adverse effects which you should know. So it can cause the galactorrhea and the gynecomastia, right? Now these drugs, they can also have some CNS effects, which includes the confusion and the altered mental status, right? They decrease the efficacy of the drugs which are requiring the acidic environment, like the ketoconazole. Then it also, these drugs, they also interfere with the metabolism of many drugs, and all except the famotidine can also inhibit the ethanol gastric first pass metabolism, especially in the women. So this is done for the estrogen receptor antagonist, and then let us continue. Okay, then we have the PPIs, which are the proton pump inhibitors. Okay, now the next class is the PPIs, which are the proton pump inhibitors, and they basically block the final step in the secretion of the gastric acid, right? The pump which I have shown you in the figure, right? Remember? And this drug class, it includes the 6 drugs, which are lansoprazole, deslinsoprazole, rabeprazole, omeprazole, esomeprazole, and the pantoprazole, right? So these 4 drugs, they are taken orally: the lansoprazole, deslinsoprazole, rabeprazole, and the omeprazole. And the esomeprazole, pantoprazole, they are taken intravenously, right? Now the mechanism of action of these drugs is that they bind to the H hydrogen potassium pump, and in this way they inhibit the acid secretion. Now, how they produce their actions? First of all, the PPIs, they are the prodrug. It means they are inactive drugs. So, okay, when they reach the stomach, the acid-resistant enteric coating, they have this coating on their on themselves, right? So this coating is basically removed when they go to the alkaline duodenum, right? And there they get absorbed and get into the blood, and where they get into the parietal cells. Okay, and in the parietal cells, these drugs, they get activated. Okay, and now what they would do, they would bind covalently with the hydrogen potassium pump, and now you know that the new pump would take 18 hours in order to regenerate. So till that hour, till that time, this acid secretion would be inhibited, and this acid secretion is inhibited in the 90% of the people or the patients. Now the uses of the PPIs is that it basically these drugs basically decrease the acid production, they increase the healing, and in the GERD the PPIs are most effective, right? And they are also used in the erosive esophagitis, in the active duodenal ulcers, in the Zollinger-Ellison syndrome, NSAID-induced ulcers, in the stress ulcers, peptic ulcers. And the PPI, when they are combined with the antimicrobial agents, they are used to eradicate the H. pylori, right? Helicobacter pylori. Then these agents, they are also used in the gastrinoma and the non-ulcer dyspepsia. Now let's discuss the pharmacokinetics of the PPIs. So orally they are well absorbed, and they basically take 30 to 60 minutes before they are taken 60 to 30 minutes before meal. So what happens is that when they are taken before the meal, the bioavailability with the food is decreased, right? Then in the liver, they are basically metabolized where? In the liver, okay? So when the liver is impaired, when the liver functions are impaired, and if there's any disease of the liver, so the dose reduction is required. And as you know that there's a covalent bonding, right? The PPIs, they do the what? Covalent bonding with the hydrogen potassium pump. So it means that they would be available for the longer period of time, right? So the longer, so they have what? The longer duration of action. And their excretion is basically happens in the urine and in the feces. Now the adverse effects of the PPIs. So the PPIs, they are generally well absorbed, but the prolonged use can lead to the decrease acidity, acidic environment would be decreased. So what happens is that the drugs, they are not absorbed, right? For example, the clopidogrel, which is normally absorbed in the acidic medium. So when the acidity of the stomach would be reduced, and what happens that this drug is not absorbed, right? And there are also certain other problems that can happen when there's a when the pH is increased. So what are these conditions is that the inflammation is increased in the gastric body, that would lead to the atrophic gastritis, right? The interstitial metaplasia can also happen, and this decreases the feedback inhibition of the gastrin. So what would happen, that the gastrin would be increased, and this would cause the hyperplasia of the ECLs and the parietal cells. Okay, and the prolonged use can also lead to dementia. And the most important adverse effect of this is that it decreases the vitamin B12 absorption, and it also decreases the calcium carbonate absorption, right? And due to which what happens, there are more chances of the hip fractures and osteoporosis. Definitely osteoporosis would lead to the hip fractures, right? So what happens, so basically these patients, they are advised to take the calcium citrate supplements with that as well. Okay. Now the adverse effects which are not much common, so these include the diarrhea, headache, abdominal pain, Clostridium difficile colitis. This is important. Okay, and there would be the increase in fact infection risk. Why? Because now the acidic secretion is inhibited, right? The PPIs are inhibiting the acid secretion, which was basically responsible to kill the microorganisms. So what would happen, there would be an increased risk of infections there, right? And the infections, as I have told you, that there would be an increased risk of infections. So the patient would have the risk of nosocomial infections, the community acquired respiratory infections as well, right? And the uncommon adverse effects are also these: the hypomagnesemia, pneumonia, acute interstitial nephritis, the chronic kidney diseases, right? Okay, now discuss the fourth class, which is a mucosal protective agent. So these are basically the cytoprotective compounds, and the function of them is that they prevent the mucosal injury, decrease inflammation, and increase healing, right? So it includes the two major category of the drugs. So first is the sucralfate, and the other is a bismuth subsalicylate, right? So what is the mechanism of action of the sucralfate is that it is basically a complex of the aluminum hydroxide and the sucrose salt, right? So when it gets into the acidic environment, what happens is that it is broken down into the sucrose sulfate and aluminium salt, and now this sucrose sulfate, which is negative, it binds to the proteins, the positive proteins which are inside the necrotic mucosa, the proteins which are present in the ulceratic area, right? So as well as in the normal area. So what would happen, it basically forms a physical barrier. It means it would form a gel like substance there, okay? And what would happen, and now this gel would protect the lumen of the stomach, and this would increase the healing and protection, right, for up to 6 hours. Then we have the bismuth subsalicylate. So it basically heals the H. pylori related peptic ulcers, and it has a antimicrobial action. It inhibits the pepsin activity. It increases the mucus, prostaglandin, and the hydrogen and the bicarbonates, right? And it also coats and protects the ulcers, and it is used to treat the traveler's diarrhea, right? It can prevent and treat as well, right? Then the adverse effects of the bismuth subsalicylate is that it basically causes a harmless blackening of the tongue and stool. It is for the duodenal ulcers, and it decreases the UGI bleeding, right? And it also prevents the stress-related ulcers. And the limited use, why its use is limited? Why? Because it actually causes the multiple drug interactions, as well as the daily dosing is also required. That's why the use has been limited. Now the adverse effects, so the adverse effects are basically very much less. So it is only 3% absorbed in the body. That's why the adverse effects are very much low. Okay, now we're going to discuss the fifth category, which is the prostaglandins. So basically the function of the prostaglandin is that it would decrease the acid secretions, right? So you remember that I've told you, when the prostaglandins bind to the receptor, it basically has the G inhibitory role. So what it would do, it would function opposite to all these other three receptors, right, it would decrease the HCl secretion. So now you understood that. Okay, so the drugs that are included in this category is only one, which is the misoprostol, and the action is that the misoprostol has both the acid inhibitory and the mucosal protective properties. Okay, then the misoprostol, it decreases the acid, that's why it has a acid inhibitory property, right, and it increases the mucus and bicarbonates, that's why it has a mucosal protective property. Okay, now the deficiency of the prostaglandin, it leads to the peptic ulcer, that's why we should have a normal maintained amount or the concentration of the prostaglandin in the body. Now the uses of the prostaglandin is that the misoprostol is that it is approved for the NSAID induced gastric ulcer, so for the moderate to high risk. Okay, and the contraindication is that it is contraindicated in the early pregnancy because it stimulates the uterine contraction and may lead to the miscarriage, right? That's why it is contraindicated in what? In the early pregnancy. Then the adverse effect includes the dose related diarrhea, which is most common. Okay, now let's discuss the last category of the drugs. So this last category is the antacids, and the purpose of the antacid is that it neutralizes the already secreted HCl into the stomach. So the mechanism of action is that the antacids, they are the weak bases, and when they are combined with the gastric acid, the gastric acid is neutralized, right? So the neutralization action is the neutralization phenomenon occurs. So this gastric acid would be converted into the salt plus water, and in this way the pH is increased there, right? So the pepsin, as you know that the pepsin is inactivated when the pH is greater than 4. So it means that the antacids not only neutralizes the HCl, but also there is a pepsin activation when the antacids are there, right? Now the chemistry is that it has a varying varying chemistry of the antacids products, right? And this varying chemistry basically depends upon all these factors. It is based on and these factors are: number one, the chemical composition, the neutralizing ability, and the sodium content, palatability, efficacy. So if the efficacy is increased, then there would be efficient neutralization. Now the most common antacids are the aluminum hydroxide, magnesium hydroxide, calcium carbonate. And the adverse effects are also common. They're also very much important. That the aluminum hydroxide, it causes constipation, magnesium hydroxide causes diarrhea, and the calcium carbonate can lead to the milk alkalosis, right? Then calcium carbonate, it is also used for the osteoporosis, right? And the adverse effects also includes that these aluminum, magnesium, and the carbonate, these ions, they can be increased in case of the renal impairment, right? So their accumulation can be increased when the when we have a kidney disease. So these ions won't be excreted, right? So they would remain in the body and would cause their adverse effects. Okay, then we also have this agent as well, the sodium bicarbonate. So basically it is not so much used because you know that it increases the sodium load and this would lead to the metabolic alkalosis. Now the therapeutic uses of the antacids include the peptic ulcers, and they can also be used for the heartburn, GERD. The calcium carbonate can also be used as a calcium supplement for the osteoporosis. Now this is a summary which I have made for you, so that you can revise it in a minute. So for the peptic ulcer and the GERD, you can take the antimicrobial agents to eradicate the H. pylori. So this includes the quart and the triple therapy. For decreasing acids, you can use the H2 antagonist, you can use PPIs, prostaglandin E2s, inhibitors, right? The M1, the prostaglandin analog, and the M1 inhibitors. And the third category would include the antacids, which are these three, more common. Okay, then you can also use the mucosal protective agents, which include the sucralfate and the bismuth subsalicylate. So I hope that you got it, and if you have any questions, so you may comment in the comment box, and your feedbacks, they are most welcome. So okay, thank you.